topics. The breast cancer surgery, all the questions of an oncologist. We as an oncologist, what we are really wants to know from our surgical colleagues. Today we are going to discuss all those things. Today we don't follow our regular skeleton of this program. Today we will go by case discussions, and today we will more keen to get our inputs from our panel of experts. We don't have any local faculties today, so I don't think the panel of experts today here, they need really any introduction. We all know them very well. Dr. John Conivier, consultant oncologist, Dr. S.K. Farid Ahmed, Dr. Mohammad Jakirullah sir, all are very known face over here. So our today's discussion outline, today we have three case scenario, rather I should say a familiar case scenario that we usually face in a rural setup in our common practice. After that, few random questions will be there that are very burning questions regarding the surgical management in breast cancer. And we will discuss mainly on axillary management from surgical point of view. Few discussion regarding breast conservation after neoadjuvant chemotherapy, and we would like to hear few words regarding the oncoplastic surgery. So today we will try to cover all these questions, but if time won't allow us, then we can divide this program into two programs. So Tanya, first of all, please pose the question in this screen. So I'd like to request all our participants participate in this question. Some of you might find it very awkward question, but this is our real life scenario.
John joined.
Okay. So thank you, John, for joining. So only three participants responded so far. So I do believe there is no wrong answer in this time. So everybody is requested to give their answer. So we really can see what is my thought processing over done. Okay, Tanya, just stop this poll. So this is the case. You can see that the 35-year-old female patient after mastectomy and axillary dissection, histopathology comes that the tumor size is 4.5 centimeter, IDC grade 2, but the margin is positive. We really don't know which margin. Though the surgeon mentioned that axillary dissection was done, but histopathological specimen, no lymph node was there. So finally, they conclude that pathological T2NX, MX disease. After that, immunohistochemistry, triple negative breast cancer. And in this scenario, how we will proceed? Most of our participants are in favor of re-excision, and some of them are in SLNB. But first of all, I would like to ask this question to John Conivier. The patient come to you, and what your suggestions, Dr. John?
So if they're margin positive, I'd always speak to my surgeon about re-excision of margin. So obviously it depends which margin. If the deep margin against chest wall, more tricky. But so as option A includes re-excision, I'd go with that option really. Get rid of disease and then repeat the axillary node sample. And then, given her young age, she's likely to need chemotherapy and radiotherapy. So that would be my selection. Okay, so you opted for re-excision, even considering its immunohistochemistry triple negative breast cancer. There is no information regarding the axillary status. So don't you think that what would be the axillary management right now? So it doesn't mention axillary status, but one assumes that she's had standard of care imaging on her workup, so which would probably, well, be mammogram, ultrasound, plus or minus MRI, depending on what's been demonstrated. So
Kamal bhai, please proceed.
So, John, so let us assume it was an unplanned excision. It is a
Okay.
TNBC. Now we know it's a TNBC. And say we go and find there is a axillary node positive by FNSC. Will you go for giving the chemotherapy and ask the surgeon to do the surgery later because it is a TNBC, or you want the surgeon to complete the surgery and go for adjuvant because it is a TNBC? Shumon very trickily brought the issue as a TNBC because let us consider it is an unplanned excision, and axillary dissection was not adequately done because we don't see a node, and let us say assume that we have done imaging and we found some suspicious node and FNSC came positive. So will you go for completion of the surgery, very rational, do the dissection, re-excision, and then, or as a TNBC, we know it's a 4.5 centimeter tumor, will you go for neoadjuvant and then just a devil's advocacy?
So I'd get them to clip the nodes and then give drugs and then come back after their chemotherapy to remove them.
So if I am not wrong, so what the suggestions from Dr. John, so he will opt it for the surgical management first regarding re-excision and axillary management, and later then adjuvant chemotherapy, right?
So if there's still residual, if there's suspicious nodes still left, then I would get them clipped and I'd give chemotherapy first rather than delay for another operation, because she's triple negative. So I would have ideally given neoadjuvant chemotherapy originally. The fact she's had surgery and she's still got suspicious nodes, then I would go on to give chemo now and come back and do surgery after chemotherapy. At least then you'll receive some information about the biology of the tumor in the nodes. If she has a complete response in her suspicious nodes demonstrated by fibrosis, you know a little bit of biological information about her disease.
Very fair. So Dr. S.K. Farid Ahmed, sir. So I'm sure practicing here in Bangladesh, you might face these types of scenario. So patient right now is in your chamber. What's your decision?
Thank you. First of all, in a country where node clipping facilities are available, you will not see this scenario because we will never see this scenario in England. That's guaranteed. However, certain parts of the world, we do come across these scenarios. Looking at the description, it appears to me the quality of the surgeon or the surgery is a big question mark. Well, the decision-making, let's just not get there. What I'm trying to say is, I worry whether there is a complete mastectomy is done. There is a possibility that there is a lots of breast tissue left behind, which raises the possibility of explains why the margin is positive. Secondly, the quality of surgery also is a big question mark because surgeon has documented axillary dissection where not a single lymph node was available. So that means there is a high possibility, although it's not a unplanned surgery, because if it's a mastectomy, it's not an unplanned mastectomy. It's a mastectomy, so surgeon knew that he was dealing with a cancer. The only problem was probably they didn't bother doing immunohistochemistry, which is a major mistake. Had they knew that it's a TNBC and there was a MDT, scenario could have been entirely different. The patient might have received neoadjuvant chemotherapy, genetic test, and so on and forth, or other things. But with this scenario, patient is now in the chamber, I would suggest that I would have a careful evaluation, look at the patient. If there is any breast tissue left, I knew that there is an incomplete surgery. And in that case, I would discuss two options with patient. One is a completion mastectomy if there is residual breast tissue left, and that would give me the clearance of margins. And even if it is not, we could at least say we have done completion of surgery, and we would do axillary clearance because you cannot do sentinel biopsy. We haven't got node clipping facilities available in Bangladesh. So when there is a breast tissue taken out, how are we going to do a sentinel biopsy? Where are we going to inject the dyes and isotopes or whatever? So she would need to understand there is a 30% risk of getting lymphoedemas with her arms as well. And if she chooses, we can do a simple level 1. depending on what we see on axilla during surgery, and if axillary staging was done with an ultrasound scan, if it showed lots of suspicious nodes, then you have to do a proper axillary clearance. Otherwise, I would also consider with an MDT meeting that whether we could go ahead with chemotherapy first, and then we do completion surgery with a completion mastectomy and axillary dissection or axillary clearance. So this would be my suggestions. And at the same time, I would suggest the patient should have a genetic test because it's a triple negative cancer. She is 35. So this would be my take. Thanks.
So thank you Farid bhai. So let me ask the same question to Zakirullah sir. But keeping in mind that you are sitting here in Bangladesh, and most of our surgical colleagues are very reluctant to do revised surgery after mostly after the mastectomy. So in this scenario, what we should do, Zakir bhai?
Okay, thank you very much. This is a very unusual situation, as you said, and Farid has already explained. And I can expect that thing can happen in Bangladesh, as Farid has experienced as well. Right, now, whether this is a planned operation or not, I'll just try to think systematically. First of all, the mastectomy has been done. So possibly he knew that this is a cancer, as we know. So mastectomy, whether the person has done proper mastectomy or not, of course, by inspecting the wound, you can tell whether this is half of the breast is there or not. It happened. I had a patient here came from China as well, China or Thailand, had half mastectomy has been done. Sorry, European country. And it can happen that half of the breast is actually left behind. But if I have got opportunity, I'll speak to the surgeon first, if I can talk to him. Was it a proper mastectomy or not? Or whether he has been trained or not first. Second thing is, I'm going to speak to the pathologist. Which margin is involved? If it is anterior margin, lateral, medial, whatever it is, I've got a scope to go back. If the margin is posterior, then very rarely we actually go back unless they haven't actually gone to the prepectoral fascia or pectoral muscle area as well. So if I don't have any opportunities, my examination, I agree with Farid that I will probably need to do another mastectomy to remove the rest of the breast tissues. Regarding the axilla, I think the guy actually said he has done axillary clearance. And it's very unusual that doing axillary clearance and having only no lymph node there is very unusual, but it can happen because probably he's not been trained how to do the axillary clearance. But in that situation, initially, as you said, you have done ultrasound scan and got a lymph node positive. I think only one option is left behind it later on to have axillary clearance. But if I've got a good oncologist who knows about triple negative cancer, I will probably doing staging to make sure there is nothing else anywhere, because we don't know how many lymph nodes are positive or whether the pathologist was really correctly counted the lymph nodes or not. Presume that it has been cock up everywhere. So we'll just do staging, CT scan before starting neoadjuvant chemotherapy, do neoadjuvant chemotherapy, finish the course, and then go for proper mastectomy and re-expression of the axilla or axillary clearance. That would be my advice.
So thank you, Zakir bhai. But just for your information, here in Bangladesh, particularly in the periphery, because I used to practice in Joshua, frequently I have seen some patients, operation done by some non-qualified surgeons, rather I should say, after the MBBS, the doctors are doing mastectomy. And very frequently we got this type of scenario. They have mentioned that they have done simple mastectomy axillary dissection, but actually nothing is done. The axilla is normal. With ultrasonogram, they have shown that no surgical intervention is done. But we are getting similar type of situation frequently in our routine daily practice, particularly in periphery.
Yes, I agree.
So let's move to our second case.
One point I want to add. Some of our colleagues thinks that if some margin is positive, adjuvant treatment can take care. Not only with all side. I mean, some of our colleagues believe, well, there is some margin, okay, give some radiation, give some chemo. The message is that, I mean, on earth, nothing can replace surgery. So if possible, or we always go for re-excision. That was the message from John. That was the message from Farid and Dr. Zakirullah. So this is for all our surgeon and non-surgeon colleagues, that when there is an opportunity, we should do the re-excision. We cannot say that we give radiation, we will take care. No, it is not going to happen.
So let me hear from John again. So if surgery is not possible by any means, particularly from here in Bangladesh, so can we offer radiation therapy instead of surgery? Dr. John. in positive margin?
Sorry, say that again. So if it's a positive margin, at the end of the day, it's a discussion with my surgeon, with Zach. Say, Zach, can you remove that positive margin? Histopathologically, when it's reported, it will say whereabouts it is. And if it can't be resected, it can't be resected, So, and it's also what are you defining as your positive margin? Is it R1 where you've got macroscopic residual disease, left behind, or is it your margins 0.6 millimeters, to deep? So positive margin, you need to define what it is that what you're saying for the positive margin. If you cut through tumor, then obviously that's very bad and you need to go back and get the rest of the tumor out. If it's a deep margin less than a millimeter, then often in the MDT, we'll say, well, you can't go any deeper because it is the deep margin, and we'll give radiotherapy, and I may well consider giving a boost to the clips within the tumor bed. Does that help?
Yes. Absolutely right, John. Absolutely correct.
So let's move our second case. Tanya, you just post the question in the screen. Tanya, can you hear me? So this is our real life scenario. I would like to request all the participants, please participate. So let's see our pattern of practice, because all the answers here might be right or might be wrong.
On this question, you mean this is a breast cancer patient, right? Who did not be
initially it was thought that it's a fibroid adenoma, and surgeon unintentionally
I know. Post-op, it came out as a cancer, right?
Yes.
It's not mentioned anywhere. Okay. It's IDC. Okay.
Yes, IDC.
Okay, thanks.
So Tanya, stop the poll. So this is the case, 32 years old female patient. Surgeon operated it, considering it is a fibroid adenoma, and part of the samples, not the total samples, part of the samples sent for the histopathology report, and unfortunately it comes with IDC. A metastatic workup done. After that, it's negative. And in this scenario, how we can proceed? First of all, John. Dr. John.
Yes. My feeling was IHC and then consider neoadjuvant chemo.
So you will proceed with neoadjuvant chemotherapy. Okay.
So you mentioned it was a fibroadenoma, and then it's been discovered to be cancer, and there's still tumor left behind, yeah?
Okay, so your decision is for adjuvant therapy first, and later on, what should be your surgical plan?
So that will depend on my surgeon and whether or not they feel that it's suitable for breast conserving surgery or mastectomy, I would have said. So if they've gone in to do a lumpectomy, presumably breast conserving surgery was suitable to begin with. But if we then go down the lines of neoadjuvant chemo, you'll need to implement all the necessary measures for neoadjuvant chemo. So you'll need to clip the residual disease before going on. And you'll also need to assess their lymph nodes as well. So you need to go back to the start from scratch.
So thank you, John, for for this, I think this is very awkward situation for you, but this is our real life scenario. So I think we should discuss in this case in this platform. So Dr. Farid Bhai,
Thank
what's
you.
your suggestion?
It's a typical scenario that I am coming across, particularly from the peripheral parts of Bangladesh. Surgeons do this sort of surgery, and then patient comes to us, unfortunately. Now, what the few things we need to gather these informations. What are the investigation that was done prior surgery? Because the surgeon might have thought it is just a fibroadenoma or a benign lump. That's why they did surgery. So we might have to complete a few investigations like a mammogram or a scan, at least something, since we know it is a cancer. And then the one common typical mistake, as you see, even some parts of the body, it is taught that once you take the lump out, you excise it and do a macroscopic examination. This is absolute disaster. And even worse scenario is, it gets sent to different labs after cutting the specimen, or sometimes part of the specimen is sent. So this has to be stopped. And orientation also wasn't done, preoperative core biopsy, I'm sure because of that. That's why this unplanned lumpectomy was performed. So with this current scenario, what I would explain to patient that there are a few bits are missing. We need to get all those informations. And then treatment plan wise, my recommendation would be to have a re-excision of margin with frozen section to check with the clear margins. Number one. At the same time, I would offer her axillary sentinel lymph node biopsy. We haven't got immunohistochemistry results. That information is quite important as well from that excised specimen because the sample was excised. So I'm absolutely certain there would be no way a pathologist would be able to tell whether the margins are clear or not. So I would assume I would go and excise the whole cavity margin and frozen section to check for margins. So my recommendation would be re-excision plus sentinel lymph node biopsy and adjuvant treatment as per all the other histology results at ISC. Thank you.
So thank you, Farid Bhai. So even after lumpectomy, SLNB is possible, right?
Yes, because there are breast tissue left.
So Zakir Bhai.
হ্যাঁ, খুব ইন্টারেস্টিং কেস কিন্তু আমি বেশ মজাই লাগছে কেসগুলি শুনতে. First of all, whoever actually did this operation, in a good faith, I would say, thought it's a fibroadenoma lumpectomy has been done. But I don't know whether complete lumpectomy is done or not. So I'll go back to again the drawing line. First thing to do again, triple assessment, because this patient has not been assessed properly. So what she needs to have proper mammogram, ultrasound scan, ultrasound of the axilla to see whether there's anything visible or anything left behind. It's very difficult, especially after lumpectomy. You'll see some seroma formation, so it's not very, you'll not be able to see or understand whether any tumor left or not. But in mammogram, you might be able to see that half of the tumor is probably left behind. So that is very important to do that workout first. Interestingly, this particular patient had metastatic workup has been done. I think we don't need to that metastatic workup now because we don't have any answer to these questions about, first of all, how big the cancer is, whether the lymph node status is, whether the lymph node has been involved or not. So I think instead of doing that, do basic thing, mammogram, ultrasound. She's 32. Mammogram might be very difficult to explain, but ultrasound, mammogram, and then ultrasound of the axilla. If axilla there's suspicious lymph nodes or anything, we can do FNSC. And of course, we need to know ER/PR status of these patients. Once it's done, I completely agree. If it is resectable from all these investigations, we'll do lumpectomy and sentinel lymph node biopsy, provided the lymph node is not involved. If lymph node is involved, then of course, as you said, we'll discuss with the oncologist. We can put a small marker clip into the residual tumor, start some neoadjuvant chemotherapy if that is suitable. This is a grade 3, I believe. We need to know the grade as well. We don't know here. So quite a lot of work we need to do from the start, again, as if this is a new case, unfortunately mishandled by somebody. That's my message.
So thank you, Zakir Bhai. Can you please give a message to our colleagues who are hearing from you? So regarding how we should send the histopathological specimen to histopathologist.
Okay. So as Farid said, please. I was teaching some FCPS student as well. I've seen in some booklets that you always open your specimen not for the breast cancer. They were actually talking about other cancer as well. Whenever you take out some lump, open up, dissect it, and see whether it has got good margin or not. But that practice was a very old practice. Please don't do that, because you are not pathologist. You are just a surgeon. Whenever you are taking a lump out, please keep intact and oriented that lump. Short superior, long lateral, double deep, or whatever orientation you want to do. At least 3-point orientation. Send that specimen, immediately put into the formalin so that it doesn't get decayed, and you just ask for everything including your PR status. So please don't dissect the specimen, mark the specimen, and specify which side of the breast, which area, and what kind of operation you have done, and so that the pathologists have got full understanding of that specimen. And never do any specimen unless you have done any core biopsy, especially for the breast. Don't do any operation without doing core biopsy. That's my message. Please do that. Even if it is benign, even if it is fibroadenoma, please do a core biopsy. If you are peripherally somewhere where there is no facilities for core biopsy, I know I don't support final dispersion cytology, but it still is better than doing nothing, doing lumpectomy. That's the message I have got.
So thank you, Zakir Bhai, for this very important message. I think we should really remember these two important messages of how to send the specimen. So let us proceed with our third case. So Tanya, please, case number 3. So this is a case with supraclavicular lymph node metastasis, IDC, axillary node with supraclavicular lymph node metastasis. How we are going to proceed? So only one participant responded so far. So out of 6, 4 are in favor of neoadjuvant chemotherapy, especially they favor for neck node dissection, and only 1 in favor of simple mastectomy axillary dissection followed by CTRT. Because she is not very in favor of neck dissection, and 1 don't believe in surgery, say he's more dependent on chemo radiation therapy. Okay, Tanya, stop the question. So Dr. John, first I would like to ask the question. So what is your routine practice in this scenario in supraclavicular lymph node metastasis?
I give a neoadjuvant chemotherapy, then surgery, and then regional node radiotherapy. So I treat her curatively.
So regarding the neck node dissection, what is your suggestion?
We don't normally do neck node dissection, so we'll give them chemo, assess response, and then irradiate. Hopefully they'll have fingers crossed, they'll respond to their chemotherapy. So we don't normally do neck node dissections. I don't remember the last time I had a breast cancer patient who came back with who just had a neck dissection.
So are you in favor of doing the surgery with axillary dissection after the neoadjuvant chemotherapy?
Not normally, no.
So
well, not normally. I've never done it yet in my career.
So can you please summarize your total plan regarding this patient, how you are going to proceed from starting to end?
So neoadjuvant chemotherapy, which will be AC weekly Taxol, as she's ER positive, HER2 negative, 8 cycles, and then surgery for removal of the primary tumor and axillary lymph nodes, so full axillary clearance, and then review the post-op histology, and then refer on for, hopefully, radiotherapy to the chest wall, SCF, IMC.
So even after the neoadjuvant chemotherapy, if we see that there is a residual node in the supraclav, then what you will do?
I would probably give a higher dose of radiotherapy. So boost that area rather than go in and do a surgical resection of the neck.
So thank you for your very detailed information. Let me ask the same question to Dr. S.K. Farid Ahmed. Are you in the same line with John, or you have different opinion?
Thank you. John is spot on. We would consult with the patient that actually, because the tumor biology is as such, is ER positive, HER2 negative, the downstaging rate is not that great, as high as comparing to TNBC and other groups or HER2 positive groups. So the purpose is to give attack with the neoadjuvant chemotherapy systemic approach, so that at least some response you could see, and then based on post-neoadjuvant chemotherapy, further assessment with the images and clinical examinations to decide whether what type of surgery should require residual tumor to volume to breast volume ratio. Depending on that, we decide for surgical type, whether it's a breast conserving surgery or a mastectomy, as well as axillary clearance. We would not go back. We would not do a supraclavicular nodal dissection. I've never done this, never seen it in my 25 plus years career. But again, as John has perfectly said, the radiotherapy would be offered to the breast or the chest wall, depending on what surgery we do, as well as SCF, supraclavicular fossa, and internal mammary node areas radiation, with followed by hormone therapy as well. Thanks.
So thank you for it. So Dr. Zakir Bhai, both the UK practitioners said that they are not very keen for neck node dissection. But I have got a paper, they have written down there that the UK guys are very heroic, and they used to do this neck node dissections. And there is a number of patients they done, but ultimately they don't get any benefit doing this neck surgery. So what's your final comment regarding this patient?
Okay, that's a very good thing. I mean, very interestingly, some of the oncologists believe that this is a oligometric metastasis, if it is only supraclavicular. Some of them, it's a new concept, and I've seen that paper as well. And very interestingly, I had to do neck dissection for a patient as well. I have done a couple of patients with neck dissection with the help of my ENT surgeon as well, but it does not help. Patients do die because of and also die with the complications of neck dissection with lymphedema as another problem as well. So as a whole, I would say in England, most of the centers, we do neoadjuvant chemotherapy, followed by, as Farid said and John said as well, we do radiotherapy if necessary after mastectomy or wide local excision with axillary clearance. Up to level 3 axillary clearance we normally do if that is necessary. You can pick up all these lymph nodes. But supraclavicular lymph node dissection, as I said, result is not that brilliant. So we stop doing it now.
So thank you, Zakir Bhai. So let me announce a special announcement. So to make today's program more interactive, so today all the participants are allowed to ask any questions. So if they have any question in their mind, just raise their hands. So I see Dr. Arman Reza, you have write down a question. As supraclavicular lymph node positive, should be irradiated lower cervical lymph node also. So can you please clarify what is your question, Dr. Arman?
So my question is, as because of supraclavicular lymph node is positive, so during radiation, we know that we do the tangential field as well as supraclavicular radiotherapy in our conventional practice. As because supraclavicular lymph node is positive, so should we also raise the, should we also irradiate the lower cervical, I mean the level 4 or that type of lymph node should be irradiated or not?
Okay, Arman, today's our focus only on surgical question that we should ask to our surgical partners. But okay, for your question, I think Dr. John is the right person to answer this question. Dr. John.
Yeah, I wouldn't do elective nodal irradiation of their neck. So I don't go one station above, you know, if they've got involved nodes in SCF. So I just cover the SCF nodes.
So Limapa, you have a similar type of question. Limapa, can you please ask?
What? Then in such case, what should be the radiation dose to the supraclav? John had mentioned that he will increase the dose that conventional for supraclav. So in such cases, what should be the dose?
So I'd say you need to, if there's definite macroscopic disease left in the neck, then you need a macroscopic dose. So we know that 50 and 25 is an adjuvant microscopic. So I would have said probably taking it up to 60 and 30, something along those lines. And in terms of hypofractionating to that type of level, I'd feel really uncomfortable, if I'm honest, sort of hypofractionating beyond 2.67 to the neck until we see the results of the more recent fast forward study about SCF nodal irradiation with higher doses of hypofractionation. So I'd be cautious, and I'd probably stick to 2 gray per fraction.
So you would prefer conventional fractionation?
I would, yeah, with that brachial plexus running through there. Yeah.
Thank you so much.
So there is a question from one of our surgical colleagues, Dr. Ali Nafisa. Just please ask the question. Dr. Ali Nafisa.
Thank you.
Unmute.
As it is metastatic to supraclavicular fossa, although after neoadjuvant chemotherapy, it shows that good response. What is the role of breast conserving surgery here? It is good for mastectomy or breast conserving surgery?
I have seen that Farid Bhai already answered your question. Farid Bhai, would you like to answer the question?
Is this question asked by from yourself, or you're asking on someone else's current practice? Is it your question?
Yes.
Nafisa, is that question you are asking for yourself?
Yeah.
Okay. Would you do a mastectomy just because patient is a positive node?
No, supraclavicular lymph node is positive.
So same reasoning goes for axilla. If the axillary node is positive, I mean, I know current some parts of the world, the practice is at the moment is a node positive. Even on postgraduate studies, some parts of the world that teach that patients should have mastectomy. The reality is, type of surgery in breast is not dependent on nodal status, whether it is axilla or SCF. So you would go by tumor to breast ratio, the breast tumor size, what was the outcome from neoadjuvant chemotherapy sizes. So you'd be going by based on all these informations, not to do with axillary or SCF status. Thanks. Zakir Bhai.
I agree. Nafisa, I honestly didn't expect that question should come from you, because you've been trained by Farid, so it should not have come. But anyway, that's a good question. I'm not criticizing. That's a good question, because quite a lot of patients or quite a lot of doctors can have this idea. It's already gone to supraclavicular lymph nodes. Why don't you take the mastectomy? Why don't you take the whole breast out? Farid is absolutely right. Remember one thing: when internal mammary lymph nodes are involved, do you take the breast out? You don't. So it's another area of the lymph node, supraclavicular. So that can be tackled by your chemotherapy, radiotherapy, not surgery. Some centers are doing it, but it's not right. But or right or wrong, I wouldn't say, but I think it's not really perfect, I would say. But breast cancer surgery depends on the size of the tumor and size of the breast. Always remember, lumpectomy only possible with the oncoplastic surgical procedure as well. Up to 40-50% of the breast tissue can be preserved. If somebody has got a H-cup breast, 50% breast if you remove, still it can be, you can have another 50% to remold the breast. So always remember, breast surgery, how big the tumor is, proportionate to the breast tissue, then you decide whether it's for lumpectomy or not. Nothing to do with the lymph nodes. I hope it's clear.
Yes, actually, in our post-graduation training teaching, this is that.
That's a good question. That's a good question. It's not a bad question at all.
Lots of things.
Now, that's a very good question. That's why you have to tell all these FCPS students, please, 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 if axillary lymph node positive, they used to say mastectomy. That is wrong answer. It has got nothing to do with breast conserving surgery. Thank you.
So I really believe that Dr. Ali Nafis asked this question with intention for others learning. But still the question is there, because we have a mindset. I have seen that there's a question from Dr. Shahida Alam.
No, this is not a question. I just make a comment that this is a stress 3 tumor, so it can be treated as stress 3 tumor, not a metastatic case.
So like stage 1, 3A or 3B or 3C. So it is not different whether his supraclav is involved or not.
Okay.
So Farid bhai, are you clear?
Okay. So you are just adjunct our discussion. So you are in favor with breast conservation therapy. Okay, okay, Limapat. Thank you. So Kamal bhai, should we proceed our next module? It is 4:15.
So I think as we expected that there are very good interaction going on. If our faculties agree, we can carry this discussion on next week also. So today we will continue up to 4:30, and the remaining discussion we can continue for one more week if Dr. Zakir, Dr. Farid and John agrees. Normally we are supposed to complete our breast session today, but me and Shuman was talking in the morning that there are so many issues. I mean, it is so interesting that people will be asking questions on surgeries, this type of thing. So if you think that it will be interesting, we can continue. Zakir bhai, what do you think? Participants that three of our faculties will be in the hot seat and you are invited to ask your questions. So they will come with more preparation, don't worry. So we continue for the next week, Shuman. We continue up to 4:30, then we defer it for next week. So Shuman, we proceed for, yeah.
Okay. So the first question. So in DCIS, is it possible to avoid surgery in some selected groups? Dr. Farid bhai.
Sorry. What is the question?
The question is on your screen. So the question is that in DCIS, there are some data that doing surgery is not going to offer any strong benefit. So do you believe that there are some groups of DCIS that can easily avoid surgery?
Thank you. In UK, we are currently running a trial called low-risk DCIS. The DCIS with low grade and intermediate grade DCIS, irrespective of their size, once we've done triple assessment, and patients are suitable, like no previous cancer surgery and other bilateral, whether they're not bilateral, like once the patients are suitable for those trial criteria, we would offer patients, and if they enroll themselves, those slides get to the central lab. They confirm that whether it is definitely for quality control. If they confirm that this is definitely low or intermediate grade DCIS, then we randomize patients to two groups, on surgery versus observation. And there is a possibility that, in near future, for particular types of cancer, like low-grade DCIS or intermediate grade, we might just be following up with mammograms. In fact, in that relation, I would also want to highlight another thing. In USA, there are multi-center studies going on for patients with neoadjuvant chemotherapy for invasive cancers, irrespective of their grades. If they have got complete clinical radiological response, they get repeat core biopsies every few months, I think 3 to 6 months, on that core areas. If it is clear, they just carry on without offering even surgery. So these sort of things are still evolving in the research process, but just for food for thought, I'm also sharing that type of research is also ongoing in some parts of the world. But if there is anything else, I would like to hear from the remaining rest of the honorable faculties. Thank you.
So Dr. John, would you like to add anything?
I would say, as Farid said, clinical trial personally. So yes.
So for Zakir bhai.
No, absolutely nice. I mean, I think again, same word, clinical trials going on. Loris trial in the UK is not very popular because we are doing screening mammogram here, and screening mammogram, if they find low grade or intermediate grade DCIs, 90% of the patient will jump into the okay, fine, get rid of it. Because unfortunately, that's the concept we have given to the patient, that any cancer, low grade or intermediate or high grade cancer, our concept was in that case, get rid of it. So it's very difficult to change their minds, but recruiting is going on, but very slow recruitment in that particular side. Why this question is coming out? Because we don't know the natural history of DCIS, low grade and intermediate grade, whether they will ever go into high grade or invasive cancer. We don't know. We presume that they can. That's why this particular trial has been set up, just to see whether low grade and intermediate grade, and see the natural history, 5 years of mammogram, 10 years of mammogram. It might never progress into a full-blown cancer. But obviously, that is if it is in a center where you're doing some trial, then it is acceptable to keep those patients. But don't do some patient you have seen that some low-grade, intermediate-grade DCIS without any comedonecrosis necrosis or anything like that, and say you don't need an operation. Don't do that yet, because we haven't got the conclusion yet. So if any patient group is saying, yes, it's low grade or intermediate grade, I don't want this lump to stay there, fine. But if an elderly, 70, 80, 90 years of age, and has got low grade DCIs, no comedonecrosis necrosis, and there's no real problem at all, I think we can speak to the patients and leave that one, as long as they can give the knowledge to the patient that some trial is going on, whether you should be part of the trial, or at least whether you should just wait and see what happens, rather than take it as a treatment option right at this moment. Okay.
Right.
Shumon, can I ask a question in relation to that?
Limapa, just a bit later, because Kamal Bhai raised his hand first. So after Kamal Bhai, please.
My question is supplementary to this excision to John, that we see the result of RTOG 9804 is published with 10 to 15 years of data, that a group of DCIS can avoid radiotherapy after surgery. Even in conclusion, JCO, they are telling that it is not conclusive, but because radiotherapy, should not avoid, because the radiotherapy is reducing the risk of conversion of invasive breast cancer. So what is your comment about that? Say, surgery done, low risk, can we avoid radiation, or are you still giving radiation?
No, so I'd say that we still use a kind of Van Mooy's PI approach to patients. So if they've got a score of 7, they'll come and visit me. If they've got a score less than 7, they don't normally come and see me. So we use that as our sort of trigger for radiotherapy. One thing we don't have access to is Oncotype obviously has its new DCIS genetic test, but again, we don't have access to that in the NHS in the UK, but I believe others use it in other countries. I haven't used it yet myself.
So Venue index is your criteria for selecting the adjuvant radiotherapy.
Yeah.
So that is a message, Shumon. In DCIS, by using Venue index, we can take a safe decision of giving adjuvant radiotherapy. Okay, Lima.
Yes, in relation to that question for omission of surgery in DCIS, can we omit breast cancer surgery in older women with hormone receptor positive early breast cancer? That is the UK age gap study. They presented their data last year. They did show that there is no breast cancer specific, there's no difference in the breast cancer specific mortality. But the surgery group did show better over quality of life and overall survival. So I want to know the surgeon's comment regarding that.
Limapa want to avoid surgery even for ideas.
That is UK age gap study, not me.
Yes, Limapa, I know. So let's hear from our surgical colleagues. At first, Farid Ahmed. Older age group. So can we avoid surgery?
Hormone receptor positive and early breast cancer.
I have got several hundred patients on my follow-up clinic, which I've been following them up for almost 20 plus years. The patients who are quite elderly, other comorbidities, or physically or psychologically, or other condition was not suitable for surgery, or there are certain elderly patients who are fit and well, but they refuse to do surgery. In these sort of groups of patients, if they are hormone receptor positive cancers, we just prescribe letrozole 2.5 mg once daily and just 6 months to follow up. And you'd be surprised, a good number of patients, there are complete response. And we just follow them up, like in that case, annual basis. And very rarely, few patients do have relapse, like cancer do come back after several years of hormone therapy. In that case, again, we reassess and stage, and then we just change the hormone therapy to different types. And it works like magic. So the answer is yes. Thank you.
Thank you so much. Now we have gained some confidence.
Zakir bhai,
No,
comments
I
regarding
agree.
this?
But I think, Nima, one thing we need to know for sure, for the patients we are talking about, what kind of, they have got hormone positive cancer, but whether they have got ulcerated cancer or necrotizing cancer coming through the skin or not, making all bad smell and other thing coming out. Yes, hormone can be given, but quite often you can see that they are not probably responding the way we actually have seen for other patients. So if somebody has got some sort of ulcerating cancers or fungating cancer, hormone treatment you can initially start, but if they're fit for surgery, I would probably go for toilet mastectomy or that kind of operations. But otherwise, yeah.
Zakir bhai, I asked for only early breast cancer, not fungating or ulcerated breast cancer. Early breast cancer.
Yes, absolutely fine. If they are happy, and as long as you can actually tell them, it might not cure you completely, but it can keep your cancer under control. So that is the message you have to give them, because sometimes you see good response. Yes, sometimes I've seen cancers vanishing or getting smaller, but the message is that yes, it's a good treatment, primary endocrine treatment for elderly patients, those who don't need any sort of surgical treatment at all. Yes, fine. Okay.
Thank you, Zakir bhai. John, do you have anything to add, Dr. John?
Sorry, what was the question?
So the question was, in elderly, can we avoid surgery in a good prognostic category?
I'd say you always have to balance the risk and benefit of whatever you do. So if you've got someone who's elderly with a cardiac function of a left ejection fraction of 20%, I'm sure you're going to avoid surgery, because they're more likely to die from their surgery than from their low risk DCIS. So yeah, that's what the NDT is for, and to make safe decisions for patients, to weigh the risks and benefits, I would say. So yeah, there will be patients you won't operate on because they're not fit. They're more likely to die from their surgery than from their cancer. Yes. So I hope that answers the question. I'm not sure.
Yes. We got your answer. So except those extreme cases, you are in favor of surgery. I got the message from you. Let us back from our main question, that is the DCIS. So from all our discussions, so in Bangladesh, we are not in a position to avoid surgery right now. So we have to wait till all these randomized trials are coming. But till that, we have to offer surgery for our patients in DCIS, irrespective of the grade. So Kamal bhai, I think we should stop here.
Yes, we can stop it here. And I think we invite everybody to take preparation, not to answer the question, but to make a question on the next week, so that we have all the three panel. We request John, Dr. Zakir, and Dr. Farid to be there. And we request our colleagues to talk with other colleagues. It is an exciting session, because in lifetime, you will not get these people on hot seat answering your questions. So you are allowed to ask any question related to your everyday challenges, because what you face every day, the three scenarios you created, it is almost a known face to everybody. So we should ask the question and make it clear. So I think we can stop it here today, and we can.
Can I just add one thing?
Yes,
just to appreciate, but because of this MDM, whatever we are doing now, or your meeting, I really appreciate the way you're conducting every week. It's really good for all the oncologists as well as surgeons to understand how to deal with that. Particularly, I'll actually talk about one of your our colleagues called Shakira Ahmed. She's from Chittagong. I've never seen her, but she came to me directly and about a problem with a patient, exactly unplanned lumpectomy has been done and what to do. And I was so impressed the way she did the operation. I've explained that, yeah, just go and clear the margin and do sentinel lymph node. Sitting down in Chittagong somewhere where there's probably not much facilities to do sentinel lymph node biopsy, but she did it. So I encourage everybody, we are here, Farid, me, John Connie Bear, and everybody, Kamal, and everybody from Bangladesh as well. If you need any help, just email, ask questions, and that is the way we can actually improve the whole situation. Thank you, Shakira, for your question that time.
Thank you, sir. Thank you.
So Zakir bhai, let me add that Shakira is joining from Chittagong. We have a wonderful person in Chittagong named Dr. Khandakar Azad, who is a retired professor from Chittagong Medical College, is a surgeon, and he is taking a lead of organizing all the surgeons there and trying to explore the possibility of practicing evidence-based medicine, especially.
Kamal bhai,
yes.
can I just say one
Kamal
line?
bhai, I'm very.
Yes, please go
Kamal
ahead.
bhai, you go on.
Just one line. In several months practice, like a regular practice with my sabbatical leave in Bangladesh, I have to say majority of the unplanned lumpectomy are coming from Chittagong. This is a major worry, which is why we have decided to travel to Chittagong, once every few months or once a month, just to improve the scenario. And maybe we could arrange something at that part of the world, to do some sort of teaching session. That would be really fantastic if we could gather some of the surgeons and oncologists together. We can avoid those huge number of unplanned lumpectomy that travels from Chittagong to our breast unit. You'll be surprised.
Thank you, Farid, for the
Farid
offer.
bhai, respectfully, I disagree with Farid bhai. Farid bhai is from Mymensingh Medical College and I am from Chittagong Medical College. And I have found lots of person cases from Mymensingh Medical College without an FNAC, without a biopsy, just an unplanned lumpectomy, no axillary dissection.
So Limapat,
You wanted to make some comments, I'm sure. You want to make some different comments on this.
So I just let me conclude.
Personal platform.
So you see that I have already mentioned that in Joshua I have seen. So Farid bhai claimed that he has seen from Chittagong, you are seen from Mymensingh. So that is the real scenario of Bangladesh.
That is the real
So
scenario.
everywhere you go, you will find it the same scenario. So that is the real scenario. So
Yes.
We need to go both Chittagong and Mymensingh together.
We should not divide ourselves. We should not divide ourselves. We should not divide ourselves. It's the real picture in Bangladesh, really.
Exactly. So I think I should thank all the experts today for giving their precious time for enlighten ourselves. So thank you, Dr. John Conivier, Dr. S.K. Farid Ahmed, and Dr. Zakirullah sir. And I should give a special thanks to our scientific partner Roche for giving their support. And at last, I should say that our president, Professor M.A. Haisar, is a little bit sick. So I should request all our participants to pray for his early recovery. And with all that, I would like to request our academic secretary, Dr. Ifan Kamaluddin sir, to say a few words and conclude the session. Dr. Ifan Kamaluddin sir.
So Shuman, thank you very much. I am born from Chittagong and studied in Mymensingh, so that I can. So like Shuman, I want to say that no hard feelings. It is not against anybody. I don't want to look at the picture that bad surgery is happening. I want to look at one case that Shakira has done in Chittagong. That is the hope. And that is what we want to look at. I don't want to see the half the empty. I want to see the half the full. So change are happening, things are changing, and thought process is changing. Last 1.5 years, with all your support, Oncology Club is happy to see that we are thinking in a different way. Thought process has started changing. Facilities are not there. It is not easy to make a change abruptly, but whatever is happening, say the one message that Dr. Zakir said, that somebody in Chittagong is trying to do, I think that is the change, and that is the success of all the endeavor. One night we cannot change everything, but this positive move is important. And people are now trying to understand, trying to overcome these challenges. And everywhere we don't have SNB facilities, we don't have frozen facilities. And still, people are thinking about it. So always we say that we have geographical boundary which can change the economics, but it should not change the treatment facilities. Any cancer patient, any part of the world deserve the best. So from Bangladesh, we can claim our patient deserve the best. And we are trying, Oncology Club is trying for that. And we are so grateful to our wonderful partners like Dr. John, Dr. Zakir, Dr. Farid, and all the other partners who have been supporting us, especially those who sacrifice their afternoon nap and join this program and make it successful, asking questions and making contributions. So thank you very much. We hope that next week we will meet again with bigger crowd and even with our president, Professor Heiser, because he is the most regular attendant of all the program. If you make a statistics, you will see that last 1.5 years, the highest number of participants is Professor M.A. Hai. So we are missing him today. Inshallah, we'll meet with him. And thanks to everybody and inviting everybody to join next week with a more exciting session. Shumon will create more interesting questions and we will prepare some more questions for all. So let us see the winner of last week poll and we conclude.
Kamal bhai, just 2 seconds. No
Yes.
offense, Farid bhai, I was just kidding.
No,
Just wanted to say that
Lima Pai, we know that they were kidding.
Yeah, no. I just wanted to say that I'm very honored that I'm Shakira is my friend. We are classmates. I wanted to say that.
So এর মাঝখানে আমি একটু বলে নিতে চাই যে যেটা হচ্ছে যে আমরা যেহেতু কেস বেসড ডিসকাশন করতে চাই যে কারোর যদি এরকম কোনো ইন্টারেস্টিং কেস থাকে যে রিয়েল লাইফ চ্যালেঞ্জে কাইন্ডলি আমার নাম্বারে মেসেজ করে অথবা ইমেল করে দিলে আমরা সেই কোশ্চেনটা আগামী প্রজেক্টে ডিসকাস করব। কারোর যদি এরকম কোনো কেস থাকে রিয়েল লাইফে তাহলে আমি রিকোয়েস্ট করব তাকে আমার কাছে পাঠানোর জন্য। থ্যাংক ইউ।
So last week,
yeah, Kamal bhai, please.
so Jannatul Firdaus, Mehdi Farooq and Tannim Adhikari. So our management team will send the prizes to them. So next week, 3 more prizes, and next week is the last session of breast cancer. Then we will move to lung cancer. So let us make the last session very exciting, very interesting. Responsibility goes to Shumon and to all our participants. And John going to spoil one more holiday on breast cancer. Don't worry. We are giving.
John.
So thank you very much, everybody.